We are live.
Hello. Hello, good evening, everyone.
Yeah, good evening.
So, is Dr. Deepak here? Yeah.
Yes,
We are
ma'am.
live.
Yes, ma'am.
Dr.
Deepak,
Pooja,
ma'am,
we are
please
live.
start.
Good evening, everyone. Welcome to all another ARC session under the aegis of AIOS on how to excel in your residency. That extra mile you need to walk. We often get lost in the middle of our residency, things get monotonous, and we are unable to reach our end of a goal of learning the maximum that we can. This webinar by ARC will help all residents get a pathway as to how they can excel in their residency. At the onset, we would like to thank our President AIOS, Dr. Harvansh Lal sir, and Dr. Prashant Bhawankule, Chairman ARC AIOS, for organizing this webinar. For our session today, we have our expert panelists, Dr. Rashmin Gandhi, Dr. Ragini Parekh, Dr. Satanshu Mathur, Dr. Purvi Bhagat, Dr. O.P. Anand, Dr. Ghulam Ali, and Dr. Viral Shah. We would like to thank Dr. Deepak Mishra, member ARC, for this opportunity. Sir, a few words from your side.
Thank you, Dr. Pooja, for the wonderful introduction. It's in fact dream of our president to conduct the courses basically for the young ophthalmologist and the buddy ophthalmologist. And I hope the expert panels, such a eminent expert panels, and all of you who just completed your residency and face some problems during the residency, and we can have some practical tips from each and every talk. With this word, I would like you to start the webinar with the first speaker.
We have a first speaker for this evening, Dr. Karan Bhatia, a cornea consultant in Meerut, talking to us on essentials of setting up a wet lab. So over to you.
Thank you, Prashant sir, Harvan sir, Deepak sir, for this wonderful opportunity. So I'll get straight to it. It's a very important topic, the essentials of setting up a wet lab. So wet lab is important because it's the building block of a certain skill set. It's an indispensable component in the armamentarium of a teaching hospital. It provides a safe and a standardized method for training without the risks that come while operating on the real eyes. So you can practice the surgery multiple times without any tension or complication, the risk of a complication or a failure. It gives you confidence as well. It enhances your psychomotor skills, it helps you develop a better hand-eye coordination, gives you ambidextrosity as well. And it also allows the trainers to ask, what if I do this? And you can experiment basically a lot in the wet lab. So it basically helps a trainee to be better equipped when operating on the real eye. So we have four components. The first is the space. Second would be the requirements. The requirements would include consumables, equipments, and eyeballs and their fixating devices. You also need to have a designated training curriculum for such cases. And of course, you need to take a account into the cost of the setting up. So a space would be a place where it's ideally located in the main building of the hospital, or somewhere where the residents have an easy access to. It should accommodate at least two people, that is the trainee and the trainer. An ideal room size, as you can see in this animation, is that it should be around 10 feet to 10 feet. So this was taken up with an article that we had published in the IGO in 2021. This is a picture courtesy of the same model that we took from the surgical skill transfer course, which is conducted yearly at all conferences of the All India Ophthalmological Society. This is a picture of mine at the American Academy of Ophthalmology 2022. So here, if you have a larger space, you want to have more people in the wet labs, and you can organize it in such a way, but there should be a ability to move between stations. So if this wet lab can have, you should have a phaco machine, you should have a microscope, you should have a table, a chair for the trainee and the trainer, a TV, possible for what is happening over there, along with the other things. If it's not possible over here, you can use a side scope as well to see, and because it's always better if a trainer also sees what the trainee is doing. Coming to the consumables, it depends on the type of surgery, the number of trainees. The common things would be the sutures, the gloves, the blades, the fluids, and the eyes, which could be animal, human, or artificial. So for the equipment, this is an article that we had published. So after the stuff that we have mentioned, so you need the surgical instruments for the surgery you want to practice. For example, if you want to practice a squint surgery, you need its instruments. You want to practice the cataract surgery, you need its instruments accordingly, etc. You also need to have dustbins, which are color-coded garbage with the biomedical waste guidelines. A refrigerator where you can store the eyes, particularly the animal or the human eyes. A microwave is a very useful thing because you can heat up the human nucleus that you get from an SICS. When it's hardened up a little bit, about 10 or 20 seconds in the microwave, then you can do phaco on it in a much better way. A whiteboard for teaching, a storage almirah to store all this stuff, and an air conditioner is always preferable. So coming to the eyeball and the fixating devices, it's important because a properly fixed eyeball is a very important ingredient when you're practicing in a wet lab. So you can have artificial animal and human or cadaveric eyes. The artificial eyes are something that look like this. This is from Madhu Instruments. I have no financial interest, so they're either made of wax or vinyl. And this is where you fix this thing. And this has been used, this eye mask, phaco practice eyes has been used extensively in all SSTC workshops of the AIOS as well. It allows you a good control as well. Coming to the animal eyes, you can use various animals' eyes, such as the goat eyes are ones which are readily available in India. Outside India, pig eyes are also available, so you can use whatever is available. Styrofoam heads, now let's go to their fixation. So styrofoam heads are cheap, but they lack the stability and the eye rotates a lot. So therefore, these eyeball stands come into account. This is the one by Madhu Instruments. So you can, this opens up like this. I have no financial interest again here, and you can use a goat's eye. You can put it over here. And once this is in position, you can then screw it up and this fixates nicely. If it's a little soft, you can always inject some amount of saline or RL into the or BSS into the vitreous cavity, and it becomes a little bit harder. This is another model from Madhu Instruments. Again, no financial interests. And this gives you the idea of an entire face as well. So you can keep your hands accordingly over here. And in the similar way, you just fixate it. This is another beautiful device called the Safe device by Arvind.
20 degrees. Sorry.
By the Arvind Pondicherry group by Dr. Seema Ramakrishnan. This is like a vacuum device, and it holds the eye pretty nicely. Other financial devices such as this mental mount are also available if you can look for it. But the future is 3D printing, and you can devise various types of things or the devices that you want accordingly. Various animal eyes are available, so you can practice for whatever surgery you want, from cataract to cornea to glaucoma to retina to squint, etc., or anything can be practiced on these eyes. This is a beautiful article by Dr. Amar Pujari and his team from All India Institute, where they have practiced penetrating keratoplasty over here. Again, this is from Dr. Porteous and again by Dr. Pujari on trabeculectomy and then squints. This is valve surgeries as well. This is a goat's eye integrated system which was published by the Arvind Pondicherry group, where you do a rhexis in a goat's eye and then you debulk it, and then in that debulked area you put the human nucleus and switch over the site, go to the make another incision, and then you can practice your phaco over here. So coming to the human eyes, these are either discarded, rejected eyeballs or corneas. And this is, you can do whatever you want. You can practice your suturing over here. You can open sky, try a phaco, whatever you want, because the wet lab is that opportunity that gives you this. This is when I was a resident. This is my friend who was practicing at that time. The artificial anterior chamber that we use in endothelial keratoplasty is also an extremely useful device. So you can practice your DSEC, DMEC, and whatever, all of these things, DALC as well in this using this artificial anterior chamber. The eyeball is fixed, and you can practice your various lamellar dissections over here. So this is, you can practice your DMEC also using this to find. This is a video courtesy Dr. Fogla. So the options are too many. This is another article by Dr. Fogla where the donor insertion in the artificial anterior chamber in DMEC cases can be practiced. This is me doing in his workshop a hemi-DMEC. So you can start with suturing on a thermocol, a banana, and so many eyes are there. If you want to practice applanation tonometry as well. So if you look at this, the figure G and H, we published this. And this is also available from Madhu Instruments, and you can practice your applanation tonometry on this as well. So coming to the next point, that is a designated training curriculum. You need to have one for year 1 and 2 and 3. I won't get into details, but this is also published in the article that I have shown. There are various virtual simulators available. Help Me See is one stands out, and it is available for small incision cataract surgery at various AIOS centers. And it helps you, you can see and you judge what you're doing, what mistakes you're doing. So it gives you a feedback as well. Now, the cost is a very important factor. You need your grants from various sources. You need to collaborate with nearby institutes if you don't have that many funds. And the AIOS has also launched a wet lab in Delhi in the AIS headquarters, so you can use that as well. Cost-cutting tips would be you use older microscopes or phacoemulsification machines, rejected ones, or Indian microscopes are a cheaper option. There are multiple things like that you can cut. You can use all the stuff that you use in a surgery has been discarded in your OT. You can use it there. This is a beautiful article by Dr. John Davis and Anju Kuriakose, where in the COVID time, what they've started, they set up their kitchen as a wet lab. So here, figure 1 shows a microscope simulator using a smartphone resting on 2 bottles. They used boiled potato where they've practiced phaco. They're suturing on a grape over here. They're doing a single pass 4-through pupilloplasty on a tomato skin. This is again, they're using the sewing machine technique for iododialysis repair on a tomato skin. Again, Ron has, using 3D printing, as I was saying earlier, he's printed a foot plate for a non-valved implant for glaucoma surgeries. And you can practice this in the wet lab. To conclude, practice makes perfect. And thank you for this opportunity.
Excellent, excellent talk, Karan, and you covered most of the pertinent aspect. And as you very rightly highlighted, wet lab is a very integral and important part of any residency training program. It may not give you the exact feel, but there are hacks by which you can probably come closer to what real life will look like. And in fact, even if it does not give you an exact feel, in fact, it's not that easy to do a rhexis, let's say, in an animal eye. In fact, it's much more difficult because the capsule is elastic. But then that gives you that confidence, dexterity, and stereopsis that you require. Lovely, nicely covered.
Thank you, sir.
This is one question I had, sir. This debate about, using the animal eye versus the artificial eye that is available now that we know that the 3D printed eyes are also there. So for what surgery is what recommended? If you can just point out like the basic surgery that the residents do in their residency program.
So if you're going to practice a corneal tear repair, or you want to practice a keratoplasty, you want to do a glaucoma surgery or a squint surgery, then the way to go about is the animal eye. So coming to the cataract surgeries, particularly if you're talking about phacoemulsification, then you have to choose. I would believe you should mix and use both of them, because it gives you a different feel. I myself did about 100 wax eyes before I did my first phaco. But and what I did was, because it was a mix and match. So I used to take the human nucleus from SICS cases and after the wax eye nucleus is gone, I used to put it inside there. And then I had enough space. So when I did my first phaco case, my trainer was like, how many phacos have you done? I said, this is my first phaco. And he couldn't believe it because I had done about 100 cases already in the wet lab in about 3 days. So that's what I'm trying to say. You need to mix and match. Wax size can give you a good idea of trenching, but if you need to do actually good chopping, then you need to put that human nucleus inside. So yeah.
So, and your experience with using simulators?
I haven't used simulators, but I have heard that the Help Me See simulator is an excellent one that's available in all the major institutes.
Yeah, I've used Help Me See. I've tried it out. In fact, they have now come out with their phaco module as well, which I think probably is released. They had a webinar on phaco module. They are going to charge minimal amount, but I think the SICS module is very well done. It's matured. The other thing I want to tell you is we had developed the silicone heads to practice Botox fillers and some of those oculoplasty procedure as well. So that also can be used as, to answer your question, Rohan, that I think, and as Karan mentioned, it depends upon what you want to learn.
Thank you.
We'll go ahead with the next speaker. Next up, we have Dr. Prasanna Ramesh, a glaucoma consultant and a director at the Mahatma Eye Institute. he'll be talking to us on smart pedagogical tools, the way forward for residents. Over to you, sir.
Yeah, is my screen visible?
Yes, yes.
Yeah, thank you, AOS ARC, for this wonderful opportunity. So the next few minutes, I'm going to talk on the smart pedagogical tools, not only technological aspect, but it is also something that we can work in a very smart and effective way, the way forward for residents. So this is just one of the method that personally I have utilized, or the pitfalls that I have seen, and I started innovating for my residents and fellows. And this is not the method, but this is just one of the method which can really work in your residential. So for me, it's more of a video-based or an image-based learning. And currently with the IGO videos as well, this is the videos can also be peer-reviewed. It's all PubMed indexed too. So these are some of the videos which I'm going to be talking about. One on my gonioscopy, and I'm predominantly a glaucoma person. So something will be more related to the glaucoma aspect of it. So, for example, if there's going to be a practical scenario like an iris process versus a peripheral anterior synechiae, I just take my neophyte residents or my fellows. First, I show them what is an iris process. You can see fine arborizing strands. Then I show them how it's the peripheral anterior synechiae is. It's more broad basal. It can be at any level from the Schwalbe's line to the trabecular meshwork. So this once these things are shown, and when we take them into the real battlefield, or when we tell them to put the gonio, and this is what you really need to see. So now you can see that they won't be confused, because cognitively they know how an iris process really looks like. And this allows you to visualize the structures below, as well as it does not cause any issue with the IOP, and it's physiological. So then we take them into the concepts of theory rather than going with more theoretical stuffs. We have it a more module of image-based and video-based, where now the peripheral anterior synechiae here is shown, which is more broad-based, and it is attached to the trabecular meshwork here, which could cause rise in IOP, as well as the structures behind cannot be seen. So that's how we start taking the neophyte step by step in a smart way. So this is a post-angle closure attack patient, where this you can see the classical triad of Vogts. And then when an image of this is shown, I show them this animation that we have made at our center, that this is a pupillary block where you can see the posterior iris surface in contact with the anterior lens capsule here. So the aqueous is not able to go through this route. It enters through the pupil into the AC, and then it goes to the the angle, right? So this is an animation. Again, I'm playing it for the neophytes who will be watching it. So this is a pupillary block that is happening here. The cause is actually here, but the effect happens at the angle. So now we tell them that why we go do an YAG PA. Again, this is one of the very few videos which we captured of YAG PA, which is very difficult to capture in its own way. So this is a video of ours where you can see that we are demonstrating the Van Eyck's before a YAG PA, and then how the focusing is done on the crypt. So theoretical stuffs are made more practical, so that when they see a video, they can appreciate the photo disruption here. As you can see, once the photo disruption is done, the aqueous that you can see, which is actually gushing out, all the theoretical framework or the statements that they tend to read in their textbook can actually be shown beautifully by videos, and can see that I have just enhanced the opening of this particular case here. And then the Van Eyck's is again demonstrated, and you can see a slight improvement in the Van Eyck's compared to before and after. Even a simple photo disruption, my dear friends, can see this is a video shot in iPhone 14 Pro, which is focused on a crypt, and it is being slow motion here. You can see a reddish blue light, which is slow motion, and you can see here very beautifully appreciated. So this is the photo disruption phenomenon that is happening, and the ionization can be seen as good as possible with the recent technological smartphones that we have. I'm just showing this once again. You can see the beautiful blue light that is actually happening. Again, this is a ostium, a patent one, and a block tone on the right. So more practical video-based learning is going to be the smart way forward, where even the lasers that are currently not being done, such as an SLT versus an ALT, we tend to go theoretical in this in the residents, where they have a lot of paragraphs. You can see that the spot size in an ALT is much smaller than the spot size in an SLT, and it is placed in the junction of the pigmented and the non-pigmented trabecular meshwork. And even the dyeing out of argon laser peripheral iridoplasty, which we use for oppositional angle. You can see this is an oppositional angle closure, where an ALPA, once it is done in the slightly to the periphery, you can see that how the angle is actually opening up. So you can see, I'm just showing this once again, how the laser is placed and the angle is actually opening up. So not only a cross-sectional view, multiple views of front-on view where 24 spots are placed over 360 degrees can be shown, as well as a gonioscopic view, which is not possible by text. So these are all videos made by myself, and my team here, and you can see how the laser spots pull the peripheral iris and releases the oppositional angle closure. And I also believe in 3D learning because it's a lot of three-dimensional cognitive. One of our publications in IJO where you can see, we started going into the basic sciences where we went ahead and printed the cavernous sinus, the circle of Willis, even the eyeball as well. So we felt tactile cognitive learning is going to be the future. And we started printing the structures, and we used 3D printing for something very basic. Like the circle of Willis was printed with polylactic acid and we colored it. And this is the circle of Willis, this is the cavernous sinus that you can see, and this is the eyeball also. And we used a thermopolyurethane for the retina, and even it can be used for counseling and also classes, especially where color, autofluorescence, infrared, a multimodal atlas, a retinal teaching tool for the residents of various pathologies, retinitis pigmentosa, glaucomatous nerve, retinal nerve fiber layer defects, splint hemorrhages, and you can just keep on adding your collection. And also augmented reality is something which is very, very much booming. And we started exploring into that, and it is something which is, it may seem as if it's very technical, like the Iron Man snippet that I'm just showing here. But actually, it's very easy, my dear friends. Just take a screenshot of this. We have one on the Android and one on the Apple as well. You can see that the pedagogue here with the smartphone, which we have innovated, he just moves it through thin air. But on the right-hand side, the video in the smartphone is synchronized to the view that he's seeing in his phone inside. So the classes can be taken in a more augmented reality in a simulative manner. The structures that a neophyte may not be seeing on day one in a OR or as well as in a real-time scenario, he'll be seeing the real confocal images of the retina. He can go in, he can appreciate the angles and whatnot. So we have used real fundus images, real angle images, and made these models. And you can see that counseling as well as teaching, the angle structures, the complex gonioscopic structures, the 5 structures from anterior to posterior can be beautifully shown. The fundus, as you can see in an NTG patient, or you can see the RNFL defect, which we tend to show for a neophyte, and he tends to grasp this very difficult when we show it in 90D. These can all beautifully shown in the models that we have innovated. And augmented reality is going to be the way forward in teaching, is what we have experienced, and we have evaluated it and published it in the European Journal of Ophthalmology. And we moved on to cause a 4-dimensional technology with a HoloLens. You can see that with touch. So as my friend Karan was talking about simulations, we have our own simulation, which you can see that this is also for teaching. We started with teaching. Currently, we are working on a diagnostics with an EMR as well. And I'll show you my surgical simulator too. So all the structures of 3D models can actually be evaluated. And this is again a fun way of learning, which is also published in IJO. And we have tried to push ourselves much beyond, where we have tried to incorporate the OCT images in the fundus as well, so that you can extrapolate. And when you read a pathology, you can see it rather than mentally reading it. So before treatment, how it is, after treatment, how it is, what are the signs that you are actually seeing before and after treatment, and how the multimodal imaging can be utilized for the treatment per se of it, as well as the complex neuro-ophthalmological structures, which gives nightmares for a neophyte resident. You can see the complex structures, how it is related to each other. Where is the anterior? Where is the posterior? And the surgical simulations for me started in the World Glaucoma Congress when MIX was hitting the mark in 2019, and it's been the talk of the town today. You can see this is one of the videos of the second stent first, but then I retrieved the first stent after. And then when I was retrieving it, again, I failed to close the trucker and I lost the stent in the corneal incision. So then I was able to retrieve it and again go back and place it. So these are all a learning curve that one may face in his day-to-day routine in a mixed surgery, as well as my friend Karan was talking about. This was one of my first few cases where with the simulative learning, you can see that this is the simulative metaverse, which we have done at our center. Your hands, you can see that my friend is actually moving his hands, and through the eyes, with the HoloLens, you can see that it's all like a coded that we have algorithm that we have made, that complex micro-invasive procedures as like the minimal invasive glaucoma surgeries can actually be practiced not once, twice, you can do it 100 times or more than that. So you will be able to go into the field with much better preparation, with much better tissue appreciation and ambidextrity. And you can see that when you place it right, it goes well with the green color button. And this is also evaluated and published by us. This is my daughter using it for her purpose. I think that's the idea about it. So the residents can use it for their purpose, and glaucoma simulators, not much other. Moving on to the last one, which is the subtractive learning. So if you see today in theoretical textbooks, they don't have subtraction. You feel like if you subtract some structures, it will be very useful for you, but you don't get it. So we have chosen an app where we have made buttons to subtract structures, and you will be the one who will be removing structures, and you will be learning the anatomy the way you want to learn of your choice with different organs that we have made. And also the fundus simulator with the smartphone, you move your phone into the pupil, it's three-dimensional, spatial oriented, you move in, you can come out. All these are day one, you can practice 50 to 100 times, and you can go into the surgical field much prepared. So this is the metaverse that we have made. I think we as ophthalmologists have to move the smart way around. And I, for one, always think images and basics. So these are some of their award-winning images of ours in ASCRS, but you can see all are very simple basic images like a DM detachment, of FFA of a normal disc. And this is the basic imaging that we started. And this is what imaging is going to be, the cognitive smart way forward. This is some of the cover images that we have done. It's all very basic sciences, incorporating it with technology. I think that's the way forward. If you have missed any of the videos, you can take a screenshot of this. And I'm also available on YouTube where we have published all our videos. Thank you for the opportunity once again. Thank you.
Amazing work, sir. How long has it taken you to do all this? How many years in the making?
I think I started 5-6 years back, and I don't think I've still reached even 10% of what I wanted, but I think it's
amazing work, sir. Looks excellent.
Thank you. Thank you.
Dr. Viral, sir, any comments on this?
Yeah, excellent presentation. As we all know, the smart pedagogical tools are the way forward to enhance our ophthalmological teaching experience, as well as for the novice or a new incoming budding ophthalmologist. The ever-changing technology, we cannot just practice each and everything on the patient directly, or even for diagnostics. They are changing so much rapidly in our field. The smart devices and smart pedagogy are the way forward.
Yes, sir.
The one that you were showing, sir, on the bed, that does not require a 3D glasses, or does that require the 3D glasses? The one on which on the flat surface through the phone you were projecting the retina, does that also require?
No, that doesn't require. So currently with the smartphones that we have in our pocket, the technology called LiDAR technology, it is something that when we take a selfie, right, you get a hat, you get a goggles. So with that is what we started working on. And then what we did was just a smartphone is needed. The Android app is named IMG AR. If you're having an Apple user, it's called IMG Max. So today you can get the app free of cost. So what it is you have a three-dimensional representation of the eyeball or the neuro-ophthalmological structures, and you can actually use it without any extra appendages. You just need a smartphone. You don't
need a VR headset or anything. Like, so this can be very well used to explain to patients also, not just for residents.
Correct.
Yeah, for patient education also, it can be a very helpful tool in the future.
We are also working on mix simulator as well, as many are focusing on cataract simulations, as help me see the previous speaker also was telling about it. So mix is something that is very booming, and it is the talk of the town in the glaucoma sector. So we are working on mix simulator because micro-invasive surgeries, not many simulators are available, and God's eye or the other eyes that we have, we don't get the angle structures as we really wanted to, because we don't really have that as the human eye. So we need to work on something more, and we're trying to incorporate the vectoral forces also into the picture so that we get as much as reality as possible. So as I told you, I don't think I've crossed even 10%, but it seems like a long way to go. Yeah.
Definitely, we have only scratched the surface what we can do, and we have to go a lot way forward.
Yes, sir. Thank you. Thank you.
We move ahead with our next speaker, Dr. Bhavik Panchal, a vitreoretinal consultant heading the Department of LBPI Visakhapatnam campus. He's going to be talking to us today on soft skills, what a resident must hear while listening to the patients. Over to you, sir.
Yeah, so thank you so much, AIS ARC and Dr. Pooja. First of all, wonderful, Prasanna. I have heard you before in AIC forums and all.
Thank you.
Yeah, fantastic work.
Thank you.
Kudos to you. Yes, so. Yes. So I have chosen a topic in such a way that I've labeled as patient whisperer, becoming a great physician through the power of empathetic listening. Right. So let's begin. So I want to ask a question to all our audience here. How can physicians become great by harnessing the power of empathetic listening to their patients? Okay, so imagine a healthcare system where physicians possess the power to truly understand and connect with their patients, leading to better outcomes and, more importantly, patient satisfaction. If this is achieved, we will be able to get rid of such kind of news that we see often, like doctors will want litigations which happen day in day out, right? So poor communication between the doctors and the patients is an important attributing factor. So good communication skills, if you look at it, the benefits are enormous. Few of them are, it is integral for development of meaningful and trustworthy relationship between the patient and the doctor. It also improves the diagnostic capability of the doctor. It also reduces the work stress, since you know your patient is satisfied, and because of this, your job satisfaction also improves. Right. And with this, you can also manage to learn difficult encounters. Right. With experience, what happens, you can, if there are situations which are difficult to encounter, you are much more skillful in terms of encountering them. Patient satisfaction is better, so there's better compliance on the patient side. And overall, there is a positive impact on the patient's psychology, mental health, tolerance, power, and quality of life. If we break down the components of communication between the patient and the doctor, there are verbal, non-verbal, and paraverbal. Verbal deals with the content of the message, including what words do you speak, whereas non-verbal are your posture, gesture, your facial expression, and the distance between the patient. Paraverbal is your tone, pitch, pacing, and volume of the voice in the way you talk to the patient and the attendant. If you look at the barriers of good communication, first and foremost is the lack of knowledge about the disease or the treatment per se. Right. Next comes language barrier. You may be say a resident or you residing in the western part of the country, and suddenly you may have to go to the southern part of the country. Right. Language barrier is an important point here, where you need to come across and learn that language first to avoid difficult encounters. Okay, lack of insight, again due to inadequate knowledge. And the last point is stress, tiredness, or lack of time, especially in a country like us where it's an overburdened setting. So to overcome this, empathetic listening is an important art. And this is actually an active process where information is imbibed either by verbally or non-verbally by the patient. If you learn this art, cases of litigations will be reduced as the patient is more satisfied. This listening includes verbal, non-verbal, as well as paraverbal communication. So the question is, how does one become an artist? So make the patient and attendant comfortable. Show interest in what the patient is saying with your mannerisms and body language. Right? Simple mannerisms like patting the shoulder, holding hands, nodding. Basically, you have to understand whose hand you have to hold, that certain things you need to take care of. Avoid interrupting the patient. Listen to the patient, what the patient is trying to say. Most of the answers you will be getting through the patient dialogue itself. Right? And from that, you can make a way to your diagnosis as well. While concluding, ask the patient if he would like to add something more, or if there are certain more other questions what the patient wants to ask. Start the conversation by introducing yourself. Ensure that you know the patient demographics before the patient enters your clinic. Either if there is a manual folder, go through the file, where the patient is coming from, what language the patient is comfortable. Okay, how far the patient is coming from. So you can decide the follow-up for the patient. Maintain the privacy of the patient. Ensure that you are seeing only one patient at a time. Establish eye contact and maintain it at a reasonable interval. Okay, it doesn't mean that you keep on staring at the patient. Involve the patient and attendant in proper decision making, and eventually explain the final details, your treatment plan, diagnosis in a very simple, lucid language. Next important point is not just the patients, but the attendants, because eventually the attendants are the one who are going to be caregivers for the patients. So be formal with them, appreciate their efforts in getting the patient to the clinic. Involve them in the discussion and resolve the doubts. Explain about seeking second opinion as well if you feel that the patient is dissatisfied, or if you are not confident, or if you feel there is a better person to do the job for you. Okay. Another important component here is communication with your colleagues, not just the patient. So there are doctors, including postgraduate students, fellows, interns, along with nursing and supportive staffs, which are present as a team. So avoid loose talk, respect your staff, do not scold residents or colleagues in front of other patients or attendants, and lead by setting examples. The final point here is about managing difficult encounters. So a combination of factors related to doctor or patient communication, dissatisfaction, and barriers, what I explained before, can eventually lead to a difficult encounter. The imbalance between the expectations that the patient has and what the doctor has or provided can also be a factor that can lead to such kind of a difficult encounter. So doctor has both ethical as well as professional obligation to treat the patients of their ailments. Last is breaking bad news. So not always everything goes well. This is a complex communication art which lacks, if at all you lack competence or as well as confidence in an ability to indulge this bad news to the individuals, it may actually become a difficult encounter for you. So there are keys to how one can break this bad news to individuals. Be primed up for the situation. Assess the patient's and the attendant's knowledge and the attitude. Assess the patient's desire to get the levels of details or information. Right? You may start on a positive note. You may not go into the details, the minor details of the information that you need to give. Then comes the part of actual breaking of bad news, and eventually address the patient's emotions. So be present with them, empathize with them. To conclude, empathetic listening has the potential to revolutionize healthcare, creating a more compassionate and patient-centered approach. And by becoming patient whisperers, physicians can truly make a difference in the lives of the patients, offering healing, not just physically, but emotionally and mentally as well. Thank you so much.
Thank you so much, sir. That was an excellent talk, and I completely agree with you that being empathetic towards the patient is extremely, extremely important. Because even if you've had a complication or if anything as bad has gone, but if you show empathy and you show concern, I think half your battle is already won. Dr. Purvi, your thoughts on this?
Thank you so much, Dr. Pooja, for asking. Even if you hadn't, I really wanted to comment on this presentation because this topic is very, very close to my heart. And I congratulate Dr. Bhavik for taking this up because soft skills, as all this is called, like ethics, professionalism, communication, and empathy, that has always been a part of the hidden curriculum of teaching, as we call it. And it has never been overtly, taught or assessed. But now with the new changes in the curriculum that are coming up, both competency based for the undergraduates as well as for the postgraduates, these skills are now getting emphasized and taking a part in the routine teaching and assessment programs. So this actually has to be laid emphasis on. And the two questions that would arise are, one is how to train regarding communication skills and empathy. So that is where even the faculty have to undergo a development and learn how to train the students. And second is we all also need to move from the cognitive and the psychomotor domain to these affective domain aspects. Because even if we see in the exams, most of the time it's almost always the cognitive and to some extent the psychomotor domain, the skills and some small techniques and demonstrations that we focus on. But how the student has in the background been talking to the patient or behaving with them, that we do not assess. So that is also something we really need to catch up on. And I would just like to add that I'm very passionate. I wanted to talk about this was because I have designed 2 modules on communication skills training and empathy training for postgraduate students of ophthalmology. And for communication skills, it has been published in the IG also in the 2019, one of the issues. So if anybody is interested, they can have a look. And this is exclusively focused for ophthalmology students. And one module is for communication skills training, and another one is for empathy training. So that's really very important. Thank you.
Where will we get this, the empathy training module, ma'am? That's also in IGO?
That is submitted yet, not published, but anybody who is interested, you can just get in touch with me. I can share with you the entire module design, the resources and everything.
Dr. Kamdar, sir, your thoughts on how important this communication with the patient is. Half the battle is probably won. And not just the patient, I feel that, the attendant also, because the decision maker so much depends upon the decision maker who is with the patient.
Thank you, Dr. Ram. In my opinion, the role of listening is a very important for every doctor, because if you learn patiently all the things of the patient, then you have a good idea about their empathy, emotions and all, and you will deliver your words about their problems and all. And I suggest one book on the communication, that is How to Influence People and the Friends. That is a very good book. I think every resident should read that book. It is by Dale Carnegie.
Dr. Ashwin, sir, you read that book clearly.
Long ago, I've read the book. It's really a nice book. I think it does give you, not only for patient communication, I think it gives you a lot of insight into how to be always positive and how to look at how to be grateful for what you have rather than be pessimistic and be cribbing. And I mean, one important point what Dr. Puri mentioned as well, in most of the Royal College exams, when you're talking to the patient, the examiners are right there with you, and they're also assessing how you are, simple things, how you are dealing with the patient, how you're talking to the patient. In fact, a little funny incident which a lot of seniors would relate to us, that long ago during the Royal College exam, a candidate was appearing, and there was a uvea case, and he was not really doing too well, and suddenly he realized that patient was not comfortable, so he this was on a slit lamp. So he realized that patient is not comfortable, so he stopped examination, switched off the slit lamp, and offered patient a coffee. And though he didn't do too well technically, he still passed that station because he offered coffee to the patient. Of course, that doesn't mean that you keep offering coffee every time you don't know the patient. But yeah, I mean, it just boils down to the importance of what Bhavik and Dr. Puri mentioned, that I think communication and being empathetic to patient has come to us because he's in trouble. And I think that should be always paramount in our minds when we are talking to them.
One particular question I have that's open to the panelists, sir, that often we get PL negative patients who have come, from institutes, from big institutes also. So when we get PL negative patients, how do you think we should counsel them? Because they have come with hope, right? Hope is their only thing. And we know that, PL negative patients, there can only be a miracle that they can sort of see something. Probably they won't be able to see again. So particularly PL negative patients, how do you counsel them, sir?
Now, I'll take that first, because in neuro-ophthalmology, that's what you get most of the time, even if it's not PL negative. The question that patient asks, even if, post AION, he's 3/60 and he asks us what's going to happen next. So there is a very fine balance between giving hope or keeping patients positive. But at the same time, you don't want to give false hopes to the patient. You might have to prepare the patient and the relatives for what will lay ahead. So how I deal with is that it may not change anything now, but then nothing is lost. I mean, there are two things that I say, that if one sense is taken away from you, there are other senses which will probably make up for it. Number one. Number two, for neuro-ophthalmology, which is not, for patients to know, I give them the current status of what's going on in optic nerve regeneration, for example, in my specialty. I tell them this is what is people are working on, and we are hopeful that in the next few years, one of these techniques would would bring some kind of treatment to these conditions.
Can I just comment on that?
Yes, ma'am.
Yeah, so regarding that, I would just like to say in a couple of sentences that it's not about being positive or optimistic or, giving that feel good factor to the patient. We have to be realistic at all times. It is just about how you convey that realism and the true facts to the patient that is important.
Yeah, and more often regarding that no pale patient coming from big institutes and coming to you, it's patient has come to terms basically with this condition. It's more counseling of the friends and family members, relatives. They come, okay, what can we do? What can we do? But we have to show empathy and some counseling for the relatives more than the patient.
Yes, sir, true. Moving on to our next speaker, we have Dr. Ayushi Agarwal, a keen researcher interested in the field of oculoplasty and ocular oncology. She will give her thoughts and experience on the art of writing case reports, tips and tricks. Over to you.
Thank you. Is my screen visible?
Yes, it is. It is.
Is it in the slideshow mode?
Yes, I think so. Can you change the slide? We can have a look.
Yeah.
Yeah, it's moving. It's working.
Okay. Thank you, ma'am. Thank you, AIOS ARC, for giving me this wonderful opportunity. But before we learn the art of writing a case report, let's look at why should you be writing one. So there has been a notion that case reports are the lowest level of evidence and that one must aim for something more valuable such as RCT, meta-analysis or systemic reviews. But case reports are also the base, the foundation of the pyramid that you see here. They are the first level of evidence. And the impact that case reports have created in ophthalmology are way beyond their size. For example, the observation that some patients who had chorioretinal scars and diabetes never developed proliferative retinopathy led to considering PRP as a treatment option. The recognition that macular holes might close following spontaneous posterior vitreous separation led to considering PPV as a treatment of choice. What turned out to be a product of serendipity and a humble report has changed the face of how we treat capillary hemangiomas with propranolol. And similarly, intralesional bleomycin also started out as a case report and is now extensively used in the field of ophthalmology. So within the 8 minutes allotted to me, I'm going to share 8 tips and tricks of writing a case report. So even before you begin writing, make sure you have meticulous documentation of all the relevant findings. And this also includes high quality of images, which are a prerequisite to publishing in high-end journals. You don't need a DSLR to capture good resolution images. For example, this was our recent publication from my rural center where we clicked the pictures using a mobile camera, and this got published in the British Medical Journal of Case Reports. You may have a rare case with significant clinical relevance, but if your documentation is inadequate, your case report is likely to be rejected. And as Sir William Osler, the father of modern medicine, says, I'll quote and unquote, always note and record the unusual, publish it, place it on a permanent record as a short, concise note. Such communications are always of value. The next critical step is a thorough review of literature. This will enable you to compare and contrast your case with the available literature. It helps you avoid a duplicate research, something that is already been reported. And often in residency, when we have a case, we have a very superficial knowledge of the case being dealt with, leading to a vicious cycle of submission, rejection, so on and so forth. But how do we perform this thorough review? There are several search engines, the most popular being PubMed, Web of Science, Google Scholar, and databases such as Medline. Use a combination of different keywords while searching for similar articles of interest. Always explore the references that is cited by the primary article that you are referring to. One of the things that I prefer doing is to mail myself all the relevant articles through the PubMed, which hardly takes a minute, and consolidate all of them in a single document as a ready reference so that I don't lose track on any of them. One question that may arise in your mind is, what is an appropriate literature search? So one strategy is, when you keep reviewing literature, you will start noticing a repetition of the same articles with very few new articles appearing. And that is when you know that you have adequately covered the literature. But before you begin writing, ask yourself these questions. What is the clinical relevance of my article? What is the unique selling point of my manuscript? Does my report have a learning point or a clinical message that is relevant to medical literature? And am I contributing anything to the existing literature? If any of this is a yes, please go ahead. And I would recommend a checklist approach through the CARE or case report guidelines to start writing one. It provides a step-by-step approach and consists of a title, keywords, mostly 2 to 5, and an abstract, which may be structured or unstructured depending upon the journal that you're submitting to. Then the introduction comes, which mostly talks about the gap in the literature with only limited references. This is followed by a comprehensive case description, which should be meticulous without missing out on any relevant findings. In the last section of discussion, which is, by the way, the most important, we discuss all the relevant medical literature, compare it with our case, and talk about the strengths and limitations of our case report. The primary takeaway lessons can be discussed further in the concluding lines. So for example, this was a case we published in my residency, and here we have compared our case with the available literature in a tabulated version. Then we also have what is called as the patient's perspective. It is a very important section that is only found in few select journals, and it should preferably be in the patient's own language. Next comes to study the journal that you are submitting to. Study the aims and scope, instruction to authors. Few of the journals also provide their own case templates, which is very useful. Read the guidelines thoroughly, and most of them have similar guidelines. So for imaging, for images, we have the TIFF or JPEG format with at least 300 pixels per inch resolution. Also, every journal has its own reference style, so make sure you go through it before you submit the case report. While you are writing, use reference managers. So I use EndNote, but there are also freely available reference managers such as Zotero or Medley. Remember that improper references, incorrect formatting of your manuscript, and grammatical errors lead to an outright rejection of your manuscript. Always declare your conflicts of interest or any financial disclosure or any source of funding. Individuals who do not meet the authorship criteria but have contributed in some or the other way should be acknowledged. These are a few PubMed indexed journals that accept case reports. Now, one of the most important things is the ethical consideration when you write. A case report should always be authentic and genuine. Do not fabricate ideal outcomes. We have what is called as scope guidelines, the Committee on Publication Ethics, which define the best practices in the ethics of scientific publication. This is one of the highly recommended read published in IGO by Professor Javed Ali. It has everything you need to know about authorship in scientific publications. A separate written informed consent should be obtained regarding publication of images and patient information, which, by the way, should be de-identified as much as possible. Restrict multiple or redundant publications. Avoid plagiarism. So what is plagiarism? It is the unreferenced use of published as well as unpublished ideas. So even if you are writing something in your own language, but it is derived from somebody else's idea and you are not referencing it, it accounts to plagiarism. Usually up to 10% is acceptable, but that again varies with the journal. Also, since artificial intelligence is in vogue these days, it is not permitted for scientific writing. So now you submit a case report and it gets rejected. What now? You get into what we know as the famous stages of grief with so many mixed emotions. You feel dejected, your confidence hits the rock bottom. But let me tell you, it's okay. At this point, do not put your guards down. Rise and start preparing for a revised submission. Build upon the reviewer comments and resubmit the best possible version, because persistence is the only key to success here. So to summarize it all, I just want to highlight that every case that you see in clinic is a potential case report. If it has a strong message and is clinically relevant, it's okay even if it's not a rare occurrence. Secondly, nobody becomes an academic writer in a day. So start today, start now to get acquainted with the nitty-gritties of writing a scientific article, because the sooner the better, and the more the merrier. So I would like to conclude by quoting Benjamin Franklin that either you write something worth reading or you do something worth writing. Thank you all for your patient listening.
Excellent presentation. I'm sure that the young generations who are in residency or fellowship who are stuck at crossroads that need to publish and all, how to go about with it. You've given them a step-by-step guide of how to go about with it. Thank you so much, ma'am.
Thank you.
Dr. Viral, do you have any other inputs to give on how to exactly, write articles and get them published?
That was an excellent presentation by Ayushi. She has covered all the relevant points, and she has rightly pointed out, writing a good case report involves a clear, concise, and systematic documentation. Documentation is very important whenever you go for your case writing. So, very meticulous documentation must be there.
Dr. Ashwin, sir, since you also published too much, many things. So, sir, any comments?
No, I think she covered it very well. 2 points, as she said. You don't have to or should not be ignoring case report, or it's not like it is at the lower level of your publication pyramid. And most of the residents or trainees would start writing a case report as their first step towards writing a bigger paper. So I think that was covered very well.
Thank you, sir. Next up, we have Dr. Neha Ghosh, an ocular oncology and periocular trauma consultant at LVPI Visakhapatnam campus, talking to us on how to maximize your surgical training, something which is extremely essential in today's residency and fellowship training. Over to you, ma'am.
Thank you so much. Is my screen visible?
Yes, it is.
Okay, so good evening, everyone. Thank you, Team AIOC ARC, for this wonderful opportunity and for allowing me to speak to our surgeons of the future. So today I will be talking to you all about how to maximize your surgical training during residency. I have no financial interest to disclose. So as we all know, the surgical training and the standards of surgical training throughout our country vary vastly depending upon the place that you're doing your residency in. However, even so, at the end of residency, it is still expected that the trainee will have a certain degree of surgical competency, and cataract surgeries are the most common surgeries that a resident is expected to be competent with. And cataract surgeries also have a very steep learning curve. Once you have a certain degree of mastery over cataract surgeries, it's relatively easier to learn the other surgeries as well. So now, even if you don't have a mentor hand-holding you through each and every step of each and every surgery, there are multiple other ways in which you can actually maximize your opportunities and maximize your surgical training. And I will be giving you my top 10 tips on how to do the same. So first, before even jumping into any surgery, the attitude towards learning is very important. So Nguyen and et al. Found that there were certain attributes that made the trainees more likely to be given a better training experience by the trainers, and these included eagerness. So you should always go above and beyond to try to learn something. And this translates into your trainer also being much more interested in teaching you. You should be humble. You should always, because we'll all make mistakes throughout our career, and you should always be ready to learn from each and every one of those mistakes and accept them. At the same time, you should also have confidence in yourself. This will automatically translate into your trainer having confidence to allow you to proceed to the next step. You should always be a team player. You should always try to make your colleagues and your seniors' lives easier. Always try to complete the loop and finish any task that has been assigned to you. And first and last of all, you should always be adaptable. So you should always be flexible in case of any difference in opinion. If there is something that has been told to you to do differently, you should be able to change your mindset and adapt to that new skill. Next, the wet lab. So Dr. Karan has already given us a very nice overview on how to set up a wet lab. So without much ado, you know that we all know that bow ties are easily available, and it doesn't even require any institute support. You can go out to the butcher's shop and buy a few bow ties and start practicing on them. Apart from, animal eyes, there are so many other things such as the cellophane cover of an IOL box, which you can practice a capsulorhexis on. You can practice on the peels of a tomato or a banana. You can also practice suturing on the thermocol that comes with the suture material. There are some fantastic e-learning courses as well, such as the cybersight course from Orbis International. It has pre-tests, post-tests, and multiple modules on different learning, such as cataracts, general ophthalmology, pediatric ophthalmology, and they are extremely useful. The other things like Coursera also, they also have, introduction to cataract surgery modules, which students can greatly benefit from. Apart from these e-learning courses, of course, there will always be your other fundamental routine textbooks or your PDFs that you should always go back to. And it should always be that the theory knowledge and the practical should go hand in hand. Of course, watching surgical videos is something that we all do. I think it's immensely enjoyable. And whether it's cataractcoach.com or Richard C. Allen from the University of Iowa, I mean, there's so many beautiful surgical videos out there. And for each and every single, type of surgery that you want to see, there is so much really good material out there. And there is so much which is all available for free. So you can just go back home at the end of a long day and sit and keep watching surgical videos. And this will also give you a lot of insight into how to go about your surgical steps. Next, acquaint yourself with the microscope foot pedal, and the phacoemulsification foot pedals, because this will help you, before your surgeries. This will give you an idea of where your eyes, hands, feet have to go, and you'll be much more confident when you're trying to do your surgical steps on a real patient. Simulator training. Again, we have already discussed simulator training. So Help Me See is one of these simulators which is available, and it has been found, they have published on their website that 50% reduction in live cataract surgery errors has been found with Help Me See simulation-based training. So this is a very short video on how simulator actually works. On the left side is the trainee holding the device, and on the right side is the video which shows what the trainee is doing, and this gives you a feedback and a tactile feedback on how you are performing. So the Help Me See currently has the manual SICS, phacoemulsification, suture simulation, and complication management modules. It's available in different institutes in Mumbai, Hyderabad, and Madurai at present. I'm sure a lot of our residents and trainees are familiar with the Alcon PDP training program. It's an excellent program again. There's a lot of material available online, which it includes lecture series, phaco-dynamics, anterior vitrectomy. It teaches you foot pedal control, and there will always be support during your follow-up period and cases as well. The next very important tool is the ICO OSCAR. OSCAR stands for Ophthalmology Surgical Competency Assessment Rubric. And this is present for not only for phacoemulsification, but for many other surgeries such as ECC, manual SICS, trabeculectomy, pterygium surgeries, and external DCRs as well. So the whole concept of the OSCAR rubric is that they will break down your surgery into individual components, and you will be able to score yourself on each and every one of these components. And it's very essential that you as a trainee score yourself, and then you ask the person who has trained you or has seen you operate to score you on each and every one of those aspects. And there should be a close match between your scores and your trainer scores, so that you develop that intuition also and that insight about how your surgical skill is progressing. Next, you should learn from the mistakes of others. You can't live long enough to make them all yourself. So what this basically means is that you should always try to see your other colleagues also practice, operate, you should, because they will, or that cohort will always have certain things that you will also be facing trouble with. So you don't have to wait to do this, face the same challenge. You can always talk about it, and you should always foster an environment in which all your colleagues are discussing and sharing knowledge and helping each other. So surgical video recording is extremely important. Go back home and keep examining your own surgeries, see where you've gone wrong, keep rewinding and keep seeing that. And nowadays, most microscopes come with, recording facility. Sometimes, even if they don't, you get readily available 3D printed adapters with which you can connect your phone. And this surgical video recording will also help you ultimately to not make the same mistake twice, so that you can easily and quickly move on to the next steps of your surgical training. So these are the 10 tips on how to maximize your surgical training. Thank you.
Thank you so much, ma'am, for your, step-by-step process of how you should improve your surgical training. Someone had also told me when I was in my residency that one major thing that one needs to check before you start your surgery is your interpupillary distance, because, your once you check that and you have that already set, then you never have headaches or anything. So getting the basics right from having a good chair, as well as your interpupillary distance, and all small things also make a huge difference.
Yes, ma'am. Thank you. Yes, that's true.
Dr. Veera, your comments?
Excellent presentation by Dr. Neha. As she has rightly pointed out, you have to be very meticulous while undergoing your surgical training. So you have to keep your basics right. As Dr. Pooja has already mentioned, you have to start from the basics, like getting your IPD measured, getting your IPD right, not only on the operating microscope, also on the slit lamp. That is a very important thing, because even on slit lamp, you will see lots of time you will not be able to get that stereoscopic 3D view if your IPD is mismatched, your oculars are not aligned properly, and all the ergonomics and everything apart. Wet lab is a must for your surgical training. All the institutes must have some facility for a wet lab, or facility for training on animal size or on back size or phantom eyes.
We move on to our next speaker. I believe Dr. Nilesh Kumar is not joined in yet, so we'll probably take him later on. We have Dr. Lippy Mittal, who will be talking to us on online resources for residents in ophthalmology.
I think there is no audio coming there.
Yeah, even I was wondering.
Yeah,
Dr.
there's no
Lippy, there's
audio.
no audio. There's no audio. I checked that she was unmuted also while she was talking. We can't hear you, Dr. Lippy.
I think she has to join in with a different microphone because her Zoom is not supporting that audio. She has
Okay.
to, yeah, she has to log off and log in again. So in the meanwhile, we can take the next speaker.
Yeah, sure. So we can do that. I think Dr. Rohan Mehra is busy with a patient. I can share the screen for Dr. Rakhi De Cruz is not available. So she shared her presentation. So I will just share that. And she's talking to us on plan, prepare and conquer your exams, exam preparation tips for post-graduation. I'll just share the screen. I'm also having some technical difficulty. We'll go ahead with Dr. Aarti Heda. Ma'am, are you ready with the presentation?
Good evening.
Good evening.
Am I audible?
Yes,
Yeah.
yes, you are. We'll go ahead with your presentation. Dr. Aarti Heda, a consultant at the National Institute of Ophthalmology, Pune, she'll be talking to us on must-know medical legal aspects in ophthalmology for a resident. Over to you, ma'am.
So, good evening, everyone. I'm glad that I'm not the last person to talk in the list, so that I get to eat fast. So, as a resident in ophthalmology, we are habitual of concentrating more on mastering the clinical skills, surgical skills, and clinical skills and surgical skills, and how to do the research. So but the least touched topic and least discussed topic is legal aspects in ophthalmology. So I'm going to throw some light on the important aspects in this field. I don't have any financial disclosures. So my presentation will highlight the important points like documentation, consent, Consumer Protection Act, professional indemnity insurance, and some legal terms. So let's begin with a case. This ophthalmologist on 24th day of birth had examined premature child and written in notes, no ROP seen. Child was discharged and advised to come for follow-up in a special clinic. Court observed that the OP5 should have performed retinal examination with binocular indirect ophthalmoscope on dilatation of pupil with scleral depression to ascertain avascular zone at periphery of retina. Nothing was forthcoming from the medical records at this time. Court's view was that neither had doctors done the examination for ROP, nor had they advised the follow-up. So about 6.4 million compensation was awarded in this case. So let's see another interesting case, which is of improper OPD prescription. So post-pterygium surgery, a doctor advised patient to use mitomycin C, but committed error by not prescribing medicine was to be used for how many days? So appellant, instead of coming back for checkup, continued using the mitomycin C drop without consulting the doctor, which led to damage caused in his eye. Compensation was awarded as limited negligence of doctor for not writing a complete and proper prescription, and contributory negligence by patient was held by the court because he continued to take the medicine of his own. So this is another interesting case of post-cataract surgery patient who was coolie by profession and did not rest enough after the surgery. He developed corneal injury due to the work he did in his fields. The court held that he should have been instructed about post-operative care and follow-up precautions, but the medical records were devoid of such instructions. So compensation was awarded by lower courts, upheld by National Consumer Dispute Redressal Commission. So this is a very interesting case wherein a 9-year-old child underwent squint surgery and suffered cardiac asystole towards the end of the surgery. Successful resuscitation was done, but patient continued to have episodes of asystole and bradycardia, for which pacemaker wire was placed. Unfortunately, patient died in ICU. NCDRC concluded that the consent obtained from mother of the child was just a routine consent and not really an informed consent. Although the anesthesiologist claimed that the retrovalvular block was given by the surgeon, 3 documents, that is anesthesia notes, the ophthalmic surgery notes, or the physician's progress notes, had no mention of retrovalvular block. Word glyco was written instead of glycopyrrolate in OT records, and use of such confusing abbreviations in medical record is deficiency in the service. So considering all these points, the compensation was awarded to the patient. So what do we learn from these cases? Consent can be valid consent, informed consent, express consent, or an implied consent. If appropriate consent is taken, doctor is saved from criminal cases under section 304A. Return informed valid consent has to be taken in patient's language. Better to take informed consent under the surveillance of camera and recording of voice and thumb impression. Keep the record of consent as hard copy of consent and video as a consent in the soft copy form. So when it comes to record keeping, what do we learn from these cases? Note the chronological order of progress of the disease and the treatment given. Note details of procedures or surgery or anesthesia given. Record of investigations as radiological, pathological, or reports of CT and MRI, and any other consultations should be noted in the records. Records includes record of refusal or treatment or investigation or surgery. So records, if kept up to date, comes for rescue to doctor in the CPA Act. So Medical Council of India requires the doctors to preserve OPD papers for 3 years, indoor patient for 5 years, and in cases of legal complications for 30 years. So note that adult patient record should be maintained for 3 years, but the children's record has to be maintained for 21 years. So when it comes to notes writing in OT, make sure that every drug used, batch number and expiry date is mentioned. Sterility indicator strips from every autoclaved drum is mentioned. Stickers of IOL to be stuck with patient name on it. And case paper of the patient along with the details, day-to-day notes, and short history on the last page of the case paper on discharges required. So let's look into some legal terms now. What is a civil liability? Case in CPA court, civil court, MCI, or state medical council, health services, or leaders as MP, MLA, or such authority for loss of earning due to deterioration of vision or loss of vision and becoming unfit for job or professional is all under civil liabilities. What is a criminal liability? FIR in police station, criminal case in the criminal court. The criminal complaint may be for negligence resulting in loss of vision, privation of organ, or disfigurement of face. So the another important aspect when it comes to medical legal aspects is indemnity insurance. So let's see, why do we need an indemnity insurance? High compensation approved by the Consumer Protection Act 2019. Let us think that we definitely should have indemnity insurance. So what am I talking about? District court can give punishment up to 50 lakhs, state up to 1 crore to 10 crore, and national up to above the 10 crores amount. So it's really a huge amount for someone to pay. So it's always good to have an indemnity insurance. When should I take the indemnity insurance is another question which come to our mind. It's not a mandatory requirement for resident to have indemnity insurance, but it's a good idea to have. So start the indemnity insurance policy as soon as you are in practice. If you have not taken it yet, you should take it today. And make sure that you continue it even after the retirement. The minimum advisable amount is 1 crore. And make sure that you do not allow your policy to lapse. So there are various indemnity insurance policies which are available. And one of it is by Maharashtra Ophthalmological Society, wherein they cover up to 1 crore and the premium paid is really, really small. So each and every state society nowadays have some or the other policy packages for their members. So do inquire in the state you are practicing. So under Consumer Protection Act, the doctor or hospital is sued for negligence and not for complications that are mentioned in the textbooks. So complication is actually not a negligence, but what is negligence? Let's look. Not knowing the complication has happened is a negligence. Not taking proper steps to rectify it is also a negligence. Not referring or not taking help of proper specialist is a negligence. And leaving the patient on the unqualified or underqualified staff or subordinate is a big negligence. So to end my presentation, I'll just say that problems are bound to happen. How we face them and how we overcome them will make us a better surgeon. Thank you. So Dr. Viral Shah sir is here. He is my first teacher in ophthalmology. He is my MBBS teacher, and he has been part of medical legal team. So sir, would you like to cover any points I have missed?
Yeah, excellent presentation, Aarti, as always. It was a very concise, crisp, and up to the point. And Dr. Aarti has been part of our instruction course on medical legal aspects that we run on the All India Ophthalmological conferences, as well as she is looking after that UC forum of medical legal aspects. So to add to this, after the Consumer Protection Act 2019 has been implemented now, so everyone must be on their toes, and they should be well aware of the current laws. Especially residents are not taught because they are busy in surgical and medical training only, and this aspect is a bit led by them, and even the institution don't teach them. The residents are covered by the institutions as a part of vicarious liability, so they are not much concerned. They think we are just here for training. We will go outside and we'll practice. Whatever happens. We will not be touched by the law. But now the laws have changed. Even the residents are held liable, and even though there is vicarious liability, the criminal aspects, civil aspects, as well as the most important nowadays is trial by media, especially social media. It is always there. So you have to be on your toes, and you have to be up to date your knowledge in medical negligence.
So just to add a point, the resident is not held under civil, but can definitely be held under.
Yes, because he's MBBS doctor. He's looking after the patients. He's there as an assistant surgeon or a caretaker is there. His name is there, so he will be a part of the trial. Along with he will be a party along with the main surgeon or operating surgeon on the HOD or the unit in charge, and he has to face the summons. He has to come to the, because even if after he passes his training, he gets summons after 5 years, 10 years. Whenever the court case is there, it goes on for 7 years, 10 years, 12 years, like that. So he will always get a summon till the court case is disposed of.
Basically, sir, what happens? I'm audible?
Yes, you are.
What happens? The court has taken a granted that you are a MBBS graduate, and all the MBBS graduates who are working as PSC or CST, they are the medical officers, and they are basically doing all the medical legal cases. So they treat you like that. It's not like you are resident in ophthalmology or resident in any other department. You are a MBBS graduate, which is having a permanent medical registration. And second thing, not only for the criminal cases, for the trauma and other cases too. Yes. Whatever the history is repeating, and most of the time court asks who is the first person who examined, not the unit in charge or head. So at that time, the court may call or ask a resident to come into the court and tell what was the exact finding at that time when he was the examiner. So while I just only suggest 2-3 important points, apart from that, always give a proper note of a timing, not only the date. Most of the time, the resident write 12 March or 13 March or 14, but exact timing is important, because in our cases where there is loss of vision, or some case if there is chance of endophthalmitis or the start of the treatment, then the court also has taken account what is the gap, or the treatment gap between when the patient reported to hospital and when we start the first treatment, and what was the exact time when they have received. So not only the date, I suggest all of them to write the time too. Wonderful presentation, Dr. Aarti. You have covered almost everything.
Thank you so much for the opportunity, sir.
We'll try Dr. Lipi Mittal for going again. Dr. Lipi, do you want to try?
Hi, am I audible?
Yeah, but there's an echo. If you can shut.
What about now?
Yeah, it's better now. You can continue. We can hear it.
I'm sorry for the technical glitch before. So good evening, everyone. I would like to thank AIOC ARC for providing me this opportunity. I will be talking about some of the useful online resources for residents. So there are various formats through which you can avail these resources. I will be speaking about each one of them, starting with American Academy of Ophthalmology. You can find a resident corner over here where you can browse the content which is relevant for residents. There are grand rounds, courses, webinars, multiple videos, resident lectures, and basic skill videos as well, which are usually short videos which have all the keynotes and important points which you need to remember in your clinics as well. iWiki is similar to Wikipedia, but specific to ophthalmology, which has been written by eye physicians and surgeons. There are subspecialty-wise sections present over here. You can just simply search for a topic you want information on. The interesting thing is that you can yourself edit and update iWiki articles. One network is another subdomain by American Academy of Ophthalmology, where you can have access to grand rounds and recent updates with relevant references. If you're a member of AIOS, you get one network access totally free. Speaking of AIOS, which has been guiding us through years, there is a plethora of content which is available on website in forms of journals like Indian Journal of Ophthalmology. There are various webinars which are available on YouTube, fellowship programs which provide you various short-term and long-term courses which are running across the country. eOphtha is an Indian website which provides you some of the excellent PowerPoint presentations which help you during preparation of your exams. There are some interesting blogs as well written by ophthalmologists. This website is particularly my favorite, which is designed by Dr. Timothy Root. They have animated surgical videos which expand our understanding of the concepts of ophthalmology. And this particular retinoscopy video helped me during the initial phases of my residency. iLearn is a comprehensive guide for ophthalmology where you can find DOS Times compilations, DNB question bank, self-curated iLearn notes, which have been designed by Dr. Krati Gupta ma'am and Dr. Saurabh Deshmukh sir. And there are various other exam-oriented information available on this website as well. So there are multiple YouTube channels and good YouTube resources. I will be sharing you some of the most subscribed channels. Dr. Pratyush Ranjan sir has covered a comprehensive ophthalmological videos. Dr. Uday Devgan sir has a channel called cataractcoach.com. He actually critiques and comments on the resident videos, which help us getting some information on the cataract surgeries and various steps. Dr. Deepak Megu sir's channel, Dr. Saurabh Patwardhan sir's Phaco tips. ASDI Hospitals has some of the excellent resources which are available. Whenever we enter into the residency for the freshers, we need to see SICS videos, we need to learn SICS. So AuroTube is an initiative by Arvind Eye Hospital where you can find some of the animated SICS videos as well. Shankara Academy of Vision was my favorite during the residency. There are excellent case presentations and case discussions which are available on this channel. VioTube channel by UC also has some of the greatest videos and great content to learn from. iTube is YouTube specific to ophthalmology, which has subspecialty wise videos which are available free of cost. iFocus Online also has specialty wise webinars, and mostly they have covered all the topics. Vio slides are peer-reviewed presentations which provide you excellent study material while preparing for your exams. So we can learn while observing surgeries, and we can learn by listening to the knowledge as well. So whenever you are not in a mood to see the videos, or whenever you are traveling, you can listen to these podcasts. Eyes for Ears is basically an initiative taken by some of the US residents. There is a group of 4 or 5 residents which are sitting together and basically preparing for their exams. It is a discussion kind of a podcast. Indian podcast, which is initiated by Shankara Netralaya, has some of the excellent audios. Straight from the Cutter's Mouth is a Retina podcast, and you can avail these podcasts on Spotify, Apple Podcast, and Google Podcast as well. So for the smartphone addicted residents, we have got you covered as well. My Eye Anatomy is an excellent smartphone application for beginners where they want to learn the eye anatomy. It is basically a 3D model of eye where you can rotate the eye 360 degree and learn the eye anatomy. Cataract surgery is not 100% accurate application, but for the beginners, you can learn how to make apsilovixes and how to do basic phaco steps. Octavia is another retinal visual atlas application which provides us information about some of the common retinal pathologies. Eye Grader is an application designed by Dr. John Davis, and it has all the eye gradings and classifications. Right now, this app is available on Android only. So why not gain some knowledge while scrolling down the Instagram? Ophthalmobites is an excellent Instagram handle designed by Dr. Shashwanti Mohan ma'am. They have bite-sized information about some of the relevant topics in ophthalmology, which are must-remember points. Cataract and refractive surgery today is a journal or a newspaper kind of a thing where you will get updates about cataract, refractive surgery, IOLs. Your flash notes are flash notes which will help you during the last moment revision in your examination. Another excellent Instagram handle is Eye Doctor by the name of the Eye Doc. They actually provide you with some of the important mnemonics which will help you differentiating various ocular conditions and memorizing some of them. Another ophthalmer and Dr. Manasnath's Instagram handle also provide you with some of the excellent anterior segment and retinal imaging. So for international exams, websites by Professor Dr. Chua and Professor Dr. P. Muthuswamy have all the relevant content and all the guidance required for acing these international exams. There are some websites where you can access ebooks for free, like Z Library, Anna's Archive, and Sci-Hub, but the legal status of these websites is still debatable. Grammarly is an application for grammar and language checker, and it also detects plagiarism. And Zotero is important for reference management. So there are endless resources. Please do not restrict yourself to these resources. You just have to pick whatever suits best for you, and these are just add-on tools to your textbook knowledge. Thank you.
Thank you. Thank you so much. So, sir, when it comes to preparation for examinations, Dr. Purvi ma'am, when it comes to preparation for examinations, as an examiner, what is it that you want? Like, do you want the candidate to be telling you exactly theoretically what is written in the textbook, or it can be an interpretation also?
No, it goes without saying that unless there are classifications or true definitions, understanding of the concept is very, very important. So that is what we as examiners and teachers are always looking for. And the second thing I would also like to say is now, because so much information is available online, and the way technology is advancing, the students are now focused on the high-tech things, and the basics are very frequently missed out. So if I ask a student about octa and something very hi-fi, they'll be able to tell me how to interpret an OCT angiography image and everything. But if I ask them something very basic about the lid glands or something, they fail to respond very effectively. So that is what I would look forward in the students, that the basics, clinical and otherwise, should be very clear. and then gradually moving on to the other aspects.
So there are a couple of points I would like to make, Rohan, with your permission. So she mentioned about eye focus. So obviously a lot of cataract and such applications and websites and Instagram handles were highlighted, but there is equally good amount of material available in subspecialty, which is also sometimes becomes important because a lot of times our residents would not have an good exposure to, let's say, ocular oncology or neuro-ophthalmology. So there is a website called Novel, Novel, and it has all the videos of practically every ocular motility problem that a patient can present to you under the sun. So I think that's something which would make understanding about, let's say, skew deviation or 1.5 syndrome, which comes up in your exam, but we would hardly understand it. We'll mug it up and vomit it there. So Novel is a good resource. Shankar Netralaya has a very good e-learning website called Ekalavya. It has a lot of material, videos, grand rounds, same with LVPI. So those two also are extremely important. And as Dr. Puri mentioned, there are so many now websites and YouTube channels and Instagram. It's very important that you pick the right kind of channel or resource, because now everybody has an access to portray or project whatever knowledge that they have. That does not mean that everything which is available is absolutely right. So it is important to pick and choose what resource you follow.
Rasmin sir, one question from you, from my side. You are one of the pillar of the eye focus. Just tell us what is the motivation behind, or how you people started, you and FS sir, eye focus. I have attended it during my residency since last 3-4 years, faculty too. What is the thing behind it? Means all 7 days, everyone stick to chair, started on time, finished on time. Just give us few tips to our youngster about that. Are the things how you started? What is the journey of eye focus?
No, so it actually it started the seed was sown when I was in Shankar Netralaya and when Santosh was in Ravi Prasad Eye Institute, is where we actually, during those days where there was no Zoom and the internet was not so fast, is where we started actually joint grand rounds between Shankar Netralaya and Ravi Prasad Eye Institute. It used to be in the morning, where the team from SN and LVPI used to sit together and dissect a particular case. So from there, when we joined together at Center for Sight, is where we were debating as to what kind of course. I was very keen to do a 2-day course, and he was very keen to do around 10 days course. So then it sort of a compromise was achieved to say that we'll do a 5 or 6 days course. And that's how it started. Obviously, a lot of it in a present format was completely designed by Santosh. And obviously, in his own meticulous way, he has made a brand out of this. So, yeah.
And just 2 more, we have Purvi ma'am. She has started working on and uploading some series of glaucoma. Ma'am, what are the text materials and other things? You made one website when we have discussion with you at the time when we started PG Forum, that whatever the things are there, it should be available. Ma'am, please tell us about something.
Yeah, so when I started it, it was quite novel, but now it is part of the e-learning scenario. It's actually a Moodle platform that I had designed. It's a learning management system. All of us know that. So therein I have put in a lot of resources, and I've actually designed topic-wise sessions which have all different kinds of videos, and there are presentations by faculty and other learning teaching resources. Along with it, there are assessments also. So if a student goes into this Moodle, unless they complete a particular set of sessions, they cannot access the assessment. And each assessment is also followed by a feedback also. So that is how the entire Moodle is coming up.
Thank you, ma'am. Now, Dr. Pooja, can you invite the next speaker?
Yes, we'll have Dr. Rohan Mehra, a phaco-refractive consultant at CKI Hospital, Saharanpur, talking to us on pearls of making a great presentation, focusing on the details. Over to you, Rohan.
Thank you so much. Is my screen visible?
Yes.
Yes, please.
Thank you. So I'm going to be talking about pearls of making a great presentation, focus on the detail. If you see in this photograph that I have managed to get, there is something that is written on the top right corner with blue. We remember stories better. So in any aspect of life, this has been proven by science over and over lots of times. In any aspect of life, especially when we were young, any story that is told to us sticks with us for a long time. So if anything that is told to us according to a sort of set of pattern that has been followed, that will always stick with us for a longer period of time. So your presentations should always be a cut above the rest. The thing is that what has started happening, especially in PG courses nowadays, is that the seminars that we have for particular topics that are there, it's basically copy paste of what has happened. It is passed down from the seniors down to the batches, and that same thing is getting carried on again and again. And there isn't a lot of effort amongst people to change that. And that is basically causing a lot of monotony when it comes to those lectures that happen in those seminars that happen during the PG teaching courses. So what we need to do is to work smarter, use technology to our advantage. Now, technology has evolved so much. We saw such a great presentation from Dr. Prasanna. When we are making our presentations, it should be something that makes us go, wow, it makes us remember stuff that has been told in that presentation forever. Be it in a story format, be it a quotation, or, when it comes to something technical, then also, for example, what Sir showed in his presentation, that 3D model, it will stick with you for life rather than, a plain photograph of an OCT and it is showing you that there is cystic spaces in that OCT. So we need to use that technology to our advantage. We need to update ourselves, and trust me, it saves a lot of extra effort. We can see this photograph, the old crow and the modern crow. The modern crow will just straight away use the straw to have water and not put the stones inside the flask there. What is important is that whatever is happening around us, rather than just being, whatever is given in the textbook. Of course, the editions of the textbooks, they keep changing, but we need to see as the technology is evolving. As a postgraduate student, when you're making a presentation, your presentation should always have the latest stuff that is there, that is available, that the practitioners are using these days, rather than it just having, those the stuff that is written in the textbook, the stuff, the classifications, they're all available for everybody to see. It is the practical things, it is the latest things, the latest advances that should be there in each and every presentation of ours. Remember that putting in the effort with the wrong tools will yield a zero result. As a postgraduate, I remember putting in hours and hours together to make seminars when our turn came for a particular topic. But if a wrong tool is used, a simple PowerPoint presentation with stuff written on it, and that's what is read out, it is not going to do any justice to your time and to the time of your teachers and your professors. Because if you're not adding anything to what they already know or to what your fellow PGs know, if you're a first year PG, then you have to take care that your second year, your third years are also learning from that presentation. So you need to make sure that you focus on details in those presentations, and you're anyway making the effort. Once you're making the effort, it's not going to sort of take anything away from it. It will not be good if you cannot take what is actually meant to be in that presentation from that the thing that you have presented. What happens on a lot of cases is that we feel that we're too busy for improvements. Whenever somebody is actually telling you also that you can make this presentation better in this way, or somebody is telling you that if you add this to your presentation, if you see this detail in your presentation, then it will become more beneficial for the others. You sort of feel like, no, I mean, whatever I've done, whatever effort I've put in it, that's good enough. So the easy way is, of course, like if you see this photograph, I put this photograph here on purpose. Now, this is a photograph just taken from the internet and put here. You can see that, this dreams time, that copyright is all there on that photograph. Nobody's bothered to remove that from it. So there's, of course, an easy way to do it, but nobody will remember you for, doing it at an easy way. You need to have a definition of who you are, especially as a postgraduate student. Every professor has, a memory, or every teacher of yours has a memory of you when you are doing your post-graduation. You need to define who you are. You could be that person whose presentation everybody looks forward to. Whenever your turn comes, maybe once in a month, once in 2 months, everybody will look forward that, they know that you put the right amount of effort, you've used the right tools, and your presentation will add to their knowledge. So you can be your own brand in that sense by making good presentations. More often than not, this is what happens in classes. After the PowerPoint presentation is finished, you sort of feel that, the burden has been removed from you. The teacher and the rest of the class is just looking at you and saying that, on most occasions, this hasn't added anything to us. This was just there in the textbook. You've pretty much just read out what has been written at. So why are you reading out loud all the words that are there on the PowerPoint slide? Everything that is there on the PowerPoint slide, anybody can read that, right? Also, again, there have been studies that have shown that whenever somebody is just reading out what is written on a PowerPoint slide, the person who is actually in the audience listening, their observation skills goes down. Also, they are confused whether for them to read what is written or to just listen to you on what you are reading, what is written on that text slide. Most presentations, especially during post-graduation, the 4 stages as is shown here. First 15 minutes, then the next 15, after that, the last quarter, and the 4th quarter, you're pretty much out. So if you could quit reading word for word what is on your PowerPoint slide, that would be absolutely great. And that is how it should be. There should be humor in your presentations to keep everybody awake. There should be points that, nobody else talks about, something that adds to everybody. People should actually say, brace yourself, PowerPoint slides are coming. It can be your unique selling proposition. The concept of unique selling proposition is something that you are doing. So as a PG, you can distinguish yourself from the others just by making great presentations. There are, on YouTube now, there are ways that show you how to make a great PowerPoint presentation by doing half the effort. So if you can invest maybe an hour, a couple of hours seeing those videos, or even taking those classes, there are classes that give you good PowerPoint presentation tips. If you can take those, it can become your unique selling proposition. So in the end, I'll say that details matter. It's worth waiting to get it right. And the difference between ordinary and extraordinary is that little extra. Thank you so much.
Thank you, Dr. Rohan. That was a great presentation. Dr. Ashwin Gandhi, sir, you give a lot of talks and you give a lot of presentations, especially for the eye focus. What are your thoughts on it? Do you also believe that there should be too many animations and pictures, or you should just have plain, simple slides?
No, so first of all, Rohan walked the talk. There was not a single word or a sentence or a paragraph, because a lot of times we make that mistake initially. There are 2 mistakes, I think, which we make when we are making a presentation or we are presenting in the initial period of our career. One, we don't trim down. We want to give a lot of knowledge to the audience, not realizing that when you give too much, almost everything is lost in communication. And all that knowledge, we try to put it on the slide, one for our benefit and one for the audience benefit, and that never works. So I personally feel, and I don't know whether you have seen Dr. G.N. Rao presenting, it'll always be a blue background with few words. It is called PowerPoint. So it just should be having a powerful points and not really sentences. Ideally, there should be just few words which tells the audience that next 1 minute, what you're going to talk about. Interestingly, I mean, there are these short videos in Instagram and Facebook, and where we are going, how our concentration span is. Apparently, they did a lot of, these tech companies did a lot of background search, and they realized that a lot of those shots also were not becoming popular because they didn't have cursor to make sure that you can see it faster. So even that 45 seconds video, people require that cursor to say, okay, let me skip first 10 or 15 seconds and just watch last 30 seconds. So that's where we are going. That's the kind of attention span that we are looking at, the people who are using or using up your knowledge. So I personally feel the lesser amount put on slide and lesser amount which is communicated by you, you are able to hold the attention, and then you're able to give. And it's always better to be absolutely concise and just choose your points. 8 minutes, you cannot really convey everything like what Lipi did. She would not have been able to convey everything. So she chose very wisely and gave few things which as a web resource which residents should be using. So I think it's very, very important for you to choose what you think is important and then convey it precisely.
Dr. Rohan, very nice presentation. I have one question. First is the role of AI tools in the PowerPoint presentation nowadays.
Yes, so there are, or you can use ChatGPT or AI-based tools nowadays, sir, to make these presentations. But again, fact checking is extremely important. What happens in a lot of these AI tools when they make it for you is that there isn't much of fact checking that has been done. Even some people have been trying to use that to write articles, and then also it comes out that whatever is written on that article from that ChatGPT is not correct. So again, the effort that you are putting into making that presentation, what AI will do is it will reduce that time that is required. So it can give you a blueprint of what it is, but then attention to detail has to be from you. You have to be the person who has to selectively decide from that pool also that what is the point that I want to put across and what is it that my audience can grasp. So I feel like yes, AI will help us. It will help us in getting that framework, but it will never be able to replace, of course, the point that you personally would want to put forward in that particular presentation.
At the moment.
Second question, Rohan, can you give some example to how to use story in presentation?
So yes, sir. There are multiple examples I can give. So I remember that our mentor, Dr. Rohit Shetty, whenever he presents, whenever he gives a presentation, he always talks about, because he's talking about a lot of research and a lot of science that is there. So his very famous story that he always keeps telling is about a sheep and about a cow and how everyone is interlinked. So for example, you're talking about glaucoma. Let me give you that example, sir. So if you're talking about glaucoma, you're talking about phacomorphic glaucoma. So phacomorphic glaucoma, the lens, the swelling of the lens, because there is a lot of lenticular pressure, that is what is causing the glaucoma. So instead of just putting it that way, you can always put humor into it, like saying a fat belly or something like that. Give a story about a fat belly of a person, or give a story about some volcano eruption. That will always stay in the mind of the person, that when you're talking about it. So if you can link it to something, an image also for that matter, if you can link it to an image. So I remember one of my professors had linked the image of a lens to a garlic, so that it stayed in my mind forever, that this is how a lens looks. While doing the rexis also, he said, you can actually, a garlic is very, very good to practice rexis on. So that image stayed in my mind forever. So I think that's how it can be helpful.
And my
Dr.
last,
yes, sir, continue. Please continue.
my last question is how to engage audience during your presentation, because it is
the humor. I feel humor is the most essential, because if you are reading your presentation and if it's going in one single tone, there's no modulation of voice, then as I showed in my presentation, there are 4 stages, sir, to the presentation. After 15 minutes, we'll have people starting to sleep. So I think humor will play a huge role in the middle. If you can put slides that will giggle up, or, sometimes what also helps is that you can bring up something from current affairs in the middle. So for about 30 seconds or a minute, you can talk about a cricket match that's going on. You can talk about something else that's going on, so that just keeps the audience engaged.
It's a very fine line. I mean, I agree with you, Rohan, but it's a very fine line. A lot of times what happens is that humor which is tailored to your audience as to who you are talking to. Because if your humor keeps going flat, then actually it also, the whole of your presentation also goes flat. So what you're saying is absolutely right. There has to be some relief so that you have that, you're doing dumbbells and you did 8 repetition, you have that 1 minute relief and you come back and you do it fast. So presentation I think has a similar sequence.
Dr. Ron, Dr. Ayushi has a question for you. Her question is, how should the background be in the presentation? Should it be light or should it be dark? Any particular thought process? I have trained with Dr. Neil Bressler from the US Johns Hopkins. So he always used to say that many of the people sitting in the audience could be colorblind. So it is better and most, better to have a dark blue background with white text on it, which is most visible to everyone. And it has the most color contrasted presentation that, people would prefer over random different colors that could be there. That was his take.
And also about the fonts. A lot of times what happens is that you don't have the same fonts for title, or even the font will keep changing during a slide. And that can be very irritating. We don't realize it, but for an audience, it can be at a subconscious level, there can be a little jarring because it's not really symmetrical.
I think symmetry is the key word here. So I think symmetry, it has to be symmetrical. Our human mind is just trained as such that whenever we see something symmetrical, we sort of connect with it.
We search for patterns. So if it's not fitting a pattern subconsciously, we may not realize it. But if it's not fitting any pattern, is where there is a jarring.
Okay, I'll be just sharing Dr. Rakhi's presentation that she had emailed me. I hope the screen is visible.
Yes, visible.
Yep.
Audio.
Please.
Yeah.
At the outset, I would like to thank the organizers for giving me this opportunity to present in this platform. So let me share my screen. So during the first year, each one of us goes through these doubts. Should I buy all the books? Should I start reading reference books? My seniors are reading those articles. Should I start reading them also now? Should I read every day? But my suggestion is to learn the major symptomatology, standard definitions, and clinical examination. Parson and Kansky is more than enough. But you should make your basics also strong during the first year. For that, you have to read the anatomy, physiology, and also your optics and refraction. Start reading case wise. Whenever you see an interesting case in your OPD, go and read about that case on that day so that you will not forget it in your life. Try to read every day, at least for 30 minutes or 1 hour. Start making notes during your initial days itself. For example, this is the note of the gold medalist, Dr. Harini. She has separate books for each topic. This is her retina book. In the first page, she has listed out the contents. This is the notes on CRIO, where she has highlighted the main points. And when she gets some additional points from some reference books, she adds that also with a sticky note. If she reads it from the articles, she will get a photostat of that article and sticks this also to the same book so that she will not forget by the end of the 3rd year from where she had read it. For many of the topics, Kansky is more than enough, but for some topics like the LIDs, for dry eye, for pediatric and neuro-ophthalmology, Kansky is not enough. In that cases, these are the reference books which are suggested. The source is from ilearn.com. Once you become the EG-PG or the exam-going PG, start increasing your study hours. Start refreshing your refraction and the basic sciences, and create your own question bank and start preparing for case presentations. The most awaited time, the study holidays. Make a timetable for the study holidays. Mind you, study holidays is only for revision. And also try to keep the volatile topics like the optics and the diagnosis, etc. towards the end. While you're writing a theory paper, be very crisp and keep a format. This is a commonly followed format for clinical questions and investigations. Be legible, have a good handwriting. If you don't have a good handwriting, at least leave enough spaces in between so that it will look neat. Use 1 or 2 colors for highlighting. Use flowcharts. It will fetch you more points. Draw big diagrams and leave spaces above and below it and label only towards one side. By the time you reach your final year, you should have already lost your art of writing for long hours. So practice writing papers for 3 hours, either by mock test or self-testing with all question papers, and practice time management. This is very important, or else you'll cry and come out of the exam. If you don't have much theory classes at your institute, no worries. There are major institutes which are providing classes through YouTube. For example, this is the YouTube site of RP Center, where they have already given out timetable of the upcoming classes, and even they have classes on instruments, which is usually taught only by seniors. Shankara Eye Health Foundation has a set of classes which includes diagnosis and retina advances, which is also not covered by many of the institutes. LVPA also has a set of programs for the residents, out of which my favorite is this problem-based learning modules, which is very practical exam oriented. And U&I series are also very good for your Viva answering. And attention to retention modules are small 3-minute videos. If you don't like listening to long videos, you can listen to these videos. iLearn.com has got almost everything a resident wants. You don't have to go and beg your seniors for those articles. Everything is available here. And all the question banks year-wise is also available here. Once you come to the dreaded practicals, be calm, composed, and confident. Confidence comes only by examining patients. And you should also have your case pro forma by heart. By answering, be audible and to the point. Practice, 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 because practice makes one perfect. And present cases whenever or wherever. These are some of my suggestions of the books to read for your practical exams. And iFocus has a lot of programs which are mainly practical exam oriented. They even have classes on pathology, microbiology, and even refraction by legends like Dr. Krishna Prasad. PG Examination Forum has also a set of videos which is very much useful for your practical exam. They have this YouTube site called Netra Gurukul. And if your institute does not have good quality Pendacam, ICG, and other scans available, you can go to this study group called a Spotify study group, which has got all the main scans along with the description on how to answer it. These are my acknowledgements. Thanks a lot for your patient listening.
All right. Thank you. Thank you so much. With that, we come to the end of this session today. I would like to thank AIOS ARC and Dr. Harbansh Lal, Dr. Deepak, Dr. Prashant Babankule sir for getting us all together. And there is so much to learn from all of these presentations, especially I hope I could have such a module when I was a postgraduate. But this is I would say gold, and the best part is it is going to stay on YouTube forever, and anybody who's missed it right now also can go back and have a look at it. Closing remarks, I would request the panelists, Dr. Rashmin sir, Dr. Purvi ma'am, Dr. Viral sir, and Dr. Kamdar sir to please give their closing remarks.
Yeah, echo. I mean, I thank AIOS ARC, the entire team, for this wonderful concept, and both you, Rohan and Pooja, you did an amazing job putting everything together in such a nice way and at the perfect timing. And wonderful talks, great discussion. I learned a lot. So thank you.
Great, a great webinar put up by ARC committee of AIOS. Thank you to Chairman ARC, Dr. Babankule sir, Dr. Deepak Mishra, Dr. Pooja, Dr. Moira for the wonderful opportunity. It was a pleasure learning from all the young stalwarts of our ophthalmology, and I think it will be a great help to the residents also in the future. Thank you.
Dr. Purvi ma'am, your closing remarks.
Yeah, this is actually a wonderful initiative by ARC AIOS, and it is a huge compilation of resources. So this entire 2 hours webinar itself. So it's actually a gold mine. If the residents can go through this again and again, it is going to help them a lot for sure. And it has just been a pleasure to be a part and contribute in whatever small inputs I could provide. Thank you.
It's a great opportunity, and I learn a lot. And I think it's an asset for the residents on YouTube. at ARC platform. Thank you, Deepak, and thank you, Dr. Bhavan Kulek, for the opportunity.
Thank you, sir. We see you once again for the next session of ARC.